Student Affairs, Professor Shamsidin Alausa. Professor Alausa is followed by the Dean, Faculty of Environmental Studies, Professor Michael Abiodun Oyidoye. Also, we have the Dean, Agric Management and Rural Development, Professor Aderanti Aderiton, followed by the Dean, Clinical Sciences, Professor Tinuade Ogunlesi. Also on the academic procession is the Dean, Basic Medical Science, Professor Arnold Desiagbola. After Professor Desiagbola is the Dean Science, Professor Olutunde Odetunde. Behind Professor Odetunde is the Acting Dean, Faculty of Law, Dr. Bade Akinribade. Also, we have the Dean Education, Professor Janet Adetayo. Behind Professor Janet Adetayo is the Dean, Faculty of Social Sciences, Professor Ayodele Odunlami. And after Professor Odunlami, we have the Dean, Admin and Management Sciences, Professor Muse Solanke. We have the Dean, the Provost of Babemi Awolowo College of Health Sciences, Professor M.B. Fetuga. Also, we have the Provost Postgraduate School, Professor Russell Shoboye. Behind Professor Shoboye is our bursar, Mr. Olufemi Stephen Showumi, FCA. Following closely to the bursar is the University Librarian, Professor Feritola Nike Onifade. I have next the Registrar and Secretary to Council, Dr. Bayo Orukoton. After Dr. Orukoton is the Deputy Vice Chancellor, Administration, Professor Oladipo Olubumeyin. Professor Olubumeyin is followed by the Deputy Vice Chancellor, Academic, Professor Olatundu Abosede Oderinde. And we have the inaugural lecturer for today, Professor Ayodeji Anike Olatunji. And finally, our host, the chair for today's occasion, the Vice Chancellor of our university, Professor Ayodeji Olayinka Johnson Agbola. Please put your hands together for these distinguished personalities. Thank you very much. You may have a seat. Mr. Vice Chancellor, other distinguished personalities on the high table, our very distinguished guests, gentlemen of the press, ladies and gentlemen. It's now my pleasure to invite the Registrar and Secretary to Council, Dr. Caleb Ilemubayo Olukoton, who will in turn invite the Vice Chancellor, Professor Ayodeji Agbola, to declare the 125th Inaugural Lecture of our university open. Mr. Registrar, sir.
Thank you. Your Excellencies, my Lord Spiritual and Temporal, gentlemen of the press, distinguished ladies and gentlemen, it is my pleasure to invite the Vice Chancellor, Professor Ayodeji Agbola, to declare this 125th Inaugural Lecture open. Vice Chancellor, sir.
The Principal of the University, Provost, Deans, Professors, Senior Presidents, Head of Department, Member of Senate, other members of the University Committee are present, the Inaugural Lecturer of today. all our guests, distinguished ladies and gentlemen. On behalf of Senate of this great university, I hereby declare the 125th Inaugural Lecture of this great university open.
Distinguished ladies and gentlemen, this 125th Inaugural Lecture is to be delivered by Professor Ayodiji Anike Olatuji. May I therefore invite the Vice Chancellor to introduce the Inaugural Lecturer of today. Vice Chancellor, sir.
Ladies and gentlemen, it is my pleasure to introduce to us the inaugural lecturer of today, Professor Mrs. Ayodele Anike Olatuji. Professor Ayodele Anike Olatuji was born 69 years ago to Madam Ebo Babalola and Chief Olu Babalola in Ubeju Ekiti State. Owing to the frequent transfers of her parents, her mother a primary school teacher, as well as the father of the secondary school principal, she attended several primary and secondary schools across the country during her early years. Of course, she eventually completed her secondary education at Crowder Memorial College, Lokoja, Kogi State. After her secondary education, she proceeded to the Polytechnic Ibadan, where she undertook her advanced level studies and successfully passed 3 papers. This achievement earned her admission into the College of Medicine, University of Lagos, where she obtained the Bachelor of Medicine and Bachelor of Surgery. And she thereafter moved to Obafemi Awolowo University Teaching Hospital Complex, where she had her house worship. And she also had a National Youth Service in Ubeaja, Edo State, and then Benin State. She received a specialist training in radiology at the University College Hospital in Ibadan and University of Ilorin Teaching Hospital. From the early stage of her career, Professor Olatuji distinguished herself as a pioneer in diagnostic imaging, particularly the development and application of ultrasound practice in Nigeria at a time when such expertise was still emerging in the country. Her academic and clinical experience has also benefited from international exposure between April and September 1993, where she undertook supervised radiology practice at the Central Mid-Essex Hospital in London under the National Health Service of the United Kingdom. She has remained actively engaged with global development in radiology through participation in several international conferences, including meetings of the Radiological Society of North America in the United States. An academic by excellence, Professor Olatuji is widely recognized for her pioneering contribution to ultrasound and diagnostic imaging practice in Nigeria, and she was also among the early practitioners of Doppler ultrasonography, transvaginal ultrasound, and ultrasound-guided retina, as well as breast biopsies in this country. In resource-constrained clinical settings, She demonstrated remarkable resourcefulness by conducting radium contrast studies and later oceanography without fluoroscopy during period of equipment downtime, thereby ensuring uninterrupted patient care. I think she deserves a round of applause for all this. Her scholarship output is both substantial and impactful. Professor Olatunji has authored and co-authored over 50 peer-reviewed scientific publications, including internationally in-depth journal and notable case reports across various radiological subspecialties. Our research contributions have significantly enriched medical knowledge and supported improved clinical practice within the country and beyond. And she has attended several local and international conferences where she presented well-researched papers. Her career spans over 4 decades of medical practice and more than 28 years of dedicated service in teaching and research within the university system. She is a fellow of the National Postgraduate Medical College of Nigeria in Radiology, Nigerian Medical Association, and member Medical and Dental Council Association of Nigeria, Association of Radiologists in Nigeria, and Association of Radiologists of West Africa, as well as the Radiological Society of North America. Beyond her research and clinical practice, she has demonstrated exemplary academic leadership within and outside the university. Within the university, she has served as both head and acting head of the Department of Radiology, as a member as well in the Faculty of Clinical Science Research Committee, as well as Faculty Curriculum and Evaluation Committee, among others. Outside the shore of this university, she has contributed to professional training as a national examiner for the Faculty of Radiology of the National Postgraduate Medical College of Nigeria. She is a reviewer for a number of journals: Nigerian Postgraduate Medical Journal, Nigerian Journal of Nursing, West African Journal of Radiology, Annals of Health Research, etc. Over the years, she has mentored numerous medical students, postgraduate residents who continue to benefit from her guidance and experiences. Professor Olatunji is a devoted Christian who enjoys reading, singing, and working, and she's married to a retired but not tired, popularly Professor P.O. Olatunji. And our union is blessed with 3 children. Ladies and gentlemen, today's inaugural lecture celebrates Professor Olatunji's remarkable professional journey and enduring contributions to medicine, scholarship and services to mankind. It also offers us the privilege of benefiting from the wealth of knowledge and experiences she brings to this podium. We therefore warmly invite you to listen attentively and learn as it shares insights drawn from a lifetime of 4 decades of clinical experiences, academic dedication, and service to humanity. Ladies and gentlemen, please join me in welcoming Professor Olatunji to deliver 125th Inaugural Lecture on the Senate of the University.
The Vice Chancellor, the Deputy Vice Chancellor Academic, the Deputy Vice Chancellor Administration, other principal officers of the university, provosts of colleges and the postgraduate school, deans of faculties, distinguished professors and heads of department, my teachers and esteemed colleagues, my lords, both spiritual and temporal, family and friends, gentlemen of the press, distinguished ladies and gentlemen, great words. All glory, honor, and adoration be to God Almighty, the creator of heaven and earth, who makes all things for making this day a reality in my life. I sincerely acknowledge and appreciate all who have made time to grace this occasion as I deliver this 125th Inaugural Lecture. This lecture represents not only a personal milestone, but also an academic statement on the evolving role of diagnostic radiology in patient care, medical education, and health systems within resource-limited settings. Mr. Vice Chancellor, permit me to say that this inaugural lecture is the first to be delivered from the Department of Radiology, Faculty of Clinical Sciences, Olabisi Onabanjo University, since the inception of the College of Health Sciences. I acknowledge with respect the many distinguished professors of medicine who have previously delivered their inaugural lectures in this great university. My roots. I come from a humble yet disciplined background, deeply rooted in the enduring values of education, service, faith, and integrity. I am the second child of the late High Chief Olabalola, the daughter of Chef Filipe Jekiti, and a retired secondary school principal, and the late Chief Mrs. Marcia Babalola, a devoted primary school teacher, and a loving and supporting wife. My parents, themselves educators, place great emphasis on learning, character, and service to humanity. And from an early stage of my life, they nurtured in me the aspiration to become a teacher and to live a life of purposeful service. By the grace of God Almighty, these aspirations have been fulfilled, though my parents are sadly not here to witness this historic occasion. My journey into radiology. I graduated from the University of Lagos College of Medicine by 1982 with the Bachelor of Medicine and Surgery degree. During my undergraduate training, as I rotated through the various medical and surgical specialties, I began to reflect deeply on the area of medicine that will allow me not only to be a competent physician, but also to live a life that I will demonstrate my faith and natural calling and reduce human suffering through accurate diagnosis and meaningful clinical decision making. My interest in radiology was first sparked during a home visit to one of my female lecturers, where I encountered diagnostic imaging as a powerful tool in medical practice. The interest further strengthened during my internship at Inaugural University Teaching Hospitals Complex, Wesley Guild Hospital in Ilesha. There, I witnessed firsthand the challenges faced by clinicians practicing in resource-limited settings, where the absence of adequate imaging facilities often forced difficult decisions in the care of critically ill patients. My National Youth Service at General Hospital Blaja in the Don State further confirmed my conviction I repeatedly observed, presenting with similar symptoms but suffering from different underlying conditions. In 1989, I commenced postgraduate residency training in radiology at the UCH in Ibadan. This period introduced me to the rigors of specialist training and academic research under the mentorship of distinguished teachers, particularly the late Professor S. Bila Goroye, who laid the foundation for my growth as both a clinical radiologist and a university scholar. A deeply personal tragedy further shaped my professional direction. The death of my immediate junior brother, the late Dr. Lumide Bayode Babalola, following a road traffic accident. His loss under circumstances that highlighted gaps in emergency medical training reinforced my resolve to contribute to medical education so that future doctors will be better trained, more confident, and better prepared to save lives. During my residency, I also undertook a non-secondary clinical attachment at Central Middlesex Hospital, NHS London. This experience broadened my academic horizons and strengthened my research, further preparing me for a career in academic radiology. For this inaugural lecture is drawn from the fact that radiologists are often described as shadow people. Yet, what we interpret are not shadows. but images carefully acquired. Over the past 3 decades, my work has focused on looking beyond these so-called shadows, assisting clinicians to make accurate diagnosis, improving patient care, and contributing to the reduction of morbidity and mortality in our environment. Diagnostic accuracy in radiology is influenced by several interrelated factors: the quality and age of imaging equipment, the design and location of the department, the skill of the radiographers acquiring the image, and the expertise of the radiologists interpreting it. Brief history of radiology. In 1895, a German physicist, Wilhelm Conrad Röntgen, while experimenting with the cathode rays in his laboratory, observed an unexpected glow on a nearby fluorescent screen in a darkened room. Figure 1 represents Wilhelm Conrad Röntgen. Intrigued by this phenomenon, he persuaded his wife, Frau Röntgen, to place her hands between the cathode ray tube and the screen. To his astonishment, the resulting image revealed the bones of her hand and the rings she was wearing. This accidental yet historic observation marked the birth of a new era in science and medicine. Figure 2 aptly shows Robert Röntgen. Röntgen published his findings in a paper titled On a New Kind of Rays in December 28, 1895. In keeping with scientific convention, he designated the unknown rays as X-rays, a term that has endured to this day. The discovery spread rapidly across the world and revolutionized medical diagnosis by enabling physicians for the first time to visualize internal structures without surgical interventions. In Nigeria, the first X-ray machine was installed at the General Hospital, Lagos, in 1913, marking the beginning of organized radiological practice in the country. This was followed by the installation of angiography and fluoroscopy units at the UCH Ibadan in 1961 and 72, respectively. CT was commissioned in UCH in 1995 and MRI was introduced later, while ultrasound was introduced in 1975. Radiological services in Ogun State developed more gradually. For many years, facilities consisted largely of refurbished portable and conventional X-ray machines, alongside ultrasound units of varying ages. Computer tomography was virtually non-existent until 2007. As at the time of this lecture, MRI facilities in this state remain very limited, and with only a few units available and none functional within the teaching hospital. Introduction. The relevance of imaging in clinical diagnosis. The relevance of medical imaging to accurate diagnosis is as critical as the process of clinical evaluation itself in contemporary medical practice, particularly within the framework of evidence-based medicine. Treatment is expected to be guided by what is known, demonstrable, and verifiable. Imaging provides the bridge between clinical suspicion and the diagnosis of uncertainty. In our environment, however, this process is often fraught with challenges. Patient complaints are frequently vague, though very real to them, and the history of disease is often incomplete, incoherent, or entirely unavailable. In such circumstances, imaging becomes indispensable, not merely as an adjunct, but as a central tool in clarifying diagnosis and guiding appropriate management. When imaging is unavailable, delayed, or inadequate, the risk of misdiagnosis increases, with consequences that may be financial, emotional, psychological, or even extreme cases fatal. Radiology is the medium through which clinical impressions derived from history taken and physical examinations are subjected to further scrutiny. It allows clinicians to determine whether the narrative of symptoms truly aligns with the underlying pathology responsible for the patient's ill health. As at the time of writing this lecture, Nigeria, with a population of estimated at over 200 million, has approximately 250 to 300 practicing radiologists. This translates to a ratio of roughly 1 radiologist to half a million people. This already daunting situation is further compounded by irregular electricity supply, inadequate biomedical engineering support, and shortages of trained imaging scientists and nurses, each of whom plays a critical role in image acquisition and interpretation. Mr. Vice Chancellor, sir, it is within this context that today's inaugural lecture is being delivered. It therefore gives me great pleasure to discuss who we are, what we do, and how we do what we do. As I take you through, I'll be briefly through the title, Beyond Shadows, Imaging Science and the Radiologist's Quest to Reveal the Unseen. I will also highlight simple practical recommendations for capacity building and for stimulating greater interest in the specialty among future generations. So I'll clarify some terms. The first one is, what is a shadow? A shadow is created when light is blocked by an opaque object, producing an outline or silhouette of that object. While a shadow may resemble external form, it offers no information about internal structures or composition. From a shadow alone, one cannot distinguish bone from soft tissue, nor appreciate internal relationships. A shadow, therefore, may merely suggest presence, but lack depth, detail, and diagnostic value, as seen in Figure 3. A picture is a visual representation, whether painted, drawn, or captured by a camera, while a photograph is a specific type of picture obtained using visible light to record real-life scene. Pictures and photographs are often descriptive and intuitive, yet they remain limited to surface appearances and cannot interrogate the internal workings of the human body. An image, however, is a likeness or representation of an object. In scientific terms, an image is formed when energy, such as light or other forms of radiation, interacts with an object and is reproduced on a photographic medium or electronic display. Imaging, therefore, refers to the process by which these images are acquired. In medicine, imaging encompasses a range of techniques that use different forms of energy to interrogate the human body. These include modalities that employ ionizing radiation, such as conventional X-rays, computed tomography, and nuclear studies, including the SPECT and PET, as well as non-ionizing techniques such as ultrasonography and magnetic resonance imaging. In each case, energy interacts with body tissues through absorption, reflection, refraction, or emission to generate images that reveal both anatomy and function. There's also the concept of radiation safety, all right, which in a purpose-built department is very important. Radiology is therefore concerned with the safe acquisition, expert interpretation, and clinical application of medical images. Through radiology, what may appear to the untrained eye as mere shadows are transformed into meaningful diagnostic images. Images that allow clinicians to distinguish normal from abnormal, confirm or refute clinical suspicions, and ultimately guide effective and life-saving patient care. The personnel in radiology department includes the clinical radiologist, the radiographer or imaging scientist, the radiation nurse, the medical physicist, health information personnel, and other supporting staff. Together, these professionals form a cohesive team working collaboratively to ensure that radiological services are delivered with precision, safety, and compassion. Synopsis of imaging modalities. I'll start with conventional X-rays. This is the commonest imaging modality. Everybody here at one time or the other has taken a chest radiograph. Okay, so it's a common imaging modality and is widely used in rural settings. It's also the first imaging modality in normal or emergency situations. While invaluable for diagnosis, their use requires careful regulation, as excessive exposure can damage body cells. All right, this understanding has led to the development of strict safety standards and controlled environments to ensure effective imaging while protecting patients and healthcare workers. Figure 4 is the image of a conventional X-ray machine. And that's a mammographic machine shown in Figure 5 is a modification of the conventional X-ray machine. Fluoroscopy is an imaging technique that allows real-time visualization of organs in motion. This innovation transformed radiology from static image interpretation to dynamic functional assessment, enabling better appreciation of the interplay between anatomy and physiology in disease processes. Figure 6 is an image of the fluoroscopic machine. They look alike, but they are not exactly alike. the same. Okay? Ultrasonography refers to sound waves with frequencies above the audible range of human hearing. In medical imaging, frequencies between 1 and 20 megahertz are employed. These sound waves are generated by piezoelectric crystals within the transducer. When stimulated by brief electrical pulses, the reflected echoes from body tissues are then processed to form real image. Ultrasonography is non-ionizing, is inexpensive, it's portable and widely available imaging modality, making it particularly suited to resource-limited environments such as ours. Its safety profile confers a major advantage, especially the imaging of radiation-sensitive population, including children, pregnant women, and the elderly. However, its major disadvantage is being operator dependent. Any fool can operate an ultrasonography. However, your results will definitely be different from mine. Computed axial tomography represents one of the most significant advancements in diagnostic imaging. Unlike plain radiographs, which produce superimposed images, CT generates cross-sectional images by acquiring data at multiple points as X-ray beam traverses the body. These data are processed using complex mathematical algorithms and computer technology to reconstruct detailed 2- and 3-dimensional images displayed on a monitor. The earliest CT scanners were designed exclusively for imaging the head. Continued technological evolution has since led to the development of multi-slice and multi-helical CT scanners, characterized by rapid image acquisition and very thin slice thickness, often as little as 1 to 2.5 millimeters. Figure 8 is an image of a CT multi-slice multi-helical machine. This is the one we have in OOUTH. Figure 9 is the image produced from that machine, giving us the slice or the brain of the human. Radionuclide imaging, as radioisotope scanning, it represents a unique and powerful dimension of diagnostic imaging, distinguished by its ability to evaluate not only structure but function. This imaging modality utilizes ionizing radiation through the administration of a radioactive substance known as a radiopharmaceutical, which is coupled to a carrier molecule and introduced into the body by injection, inhalation, as in pulmonary ventilation studies, or ingestion. Fig 10 gives us an image of the normal radionuclide study. And if you look at the series below it, that shows the concentration of the radiopharmaceuticals in the diseased regions. Advanced in technology have further enhanced this modality. The development of single photon emission computed tomography, SPECT, has enabled the acquisition of 3-dimensional tomographic images, improving lesion localization and diagnostic accuracy. Positron emission tomography represents an even more advanced application, requiring access to a nearby cyclotron and specialized positron camera. PET imaging offers unparalleled insight into metabolic and physiological processes, often before structural changes become apparent on conventional imaging. The principal advantage of radionuclide imaging over traditional X-ray based techniques lies in its ability to provide combined anatomical and functional information. Regrettably, this important imaging modality is currently unavailable in our center and, to the best of my knowledge, remains scarce nationwide. My exposure to it occurred during my non-stipendiary clinical attachment at Central Middlesex Hospital in London in 1993. The experience was both intellectually stimulating and professionally formative, further deepening my appreciation of the role of advanced imaging in modern medicine. Magnetic resonance imaging, MRI. Mr. Vice Chancellor, sir, distinguished ladies and gentlemen, MRI represents one of the most remarkable achievements in modern diagnostic medicine. Although the first clinical MRI scanners were installed in the early 1980s, the scientific foundations of this knowledge date much earlier. The clinical application of MRI is largely based on the behavior of hydrogen protons, which are abundant in biological tissues, particularly water and fat. When placed within a strong magnetic field, these protons align either parallel or anti-parallel to the direction of the field. In the early years of MRI development, image acquisition was time-consuming, interpreting it was very challenging, and the initial imaging relied primarily on proton density differences. Today, a wide array of advanced sequences has further expanded the diagnosis scope of MRI, enabling more precise radiologic pathology correlations, and I'm sure my VC will be interested in that. MRI offers several advantages over computed tomography. It does not utilize ionizing radiation and therefore poses no known long-term radiation hazards, making it particularly valuable in pediatric imaging and for repeated follow-up studies in adults. The modality provides superior soft tissue contrast resolution. MRI can be applied to virtually every part of the body and has gained particular prominence in musculoskeletal and sports medicine. Ongoing advances in MRI technology have led to the development of specialized applications such as magnetic resonance angiography, now regarded as a gold standard for imaging cerebral vessels. MRI has also become indispensable in the evaluation of white matter diseases such as multiple sclerosis, brain tumors, and cerebrovascular disorders, including stroke and stroke-like syndromes. And I must say at this juncture, MRI offers us one of the closest imaging to the diagnosis of the various causes of headache. My contributions to knowledge. Revealing the unseen, the radiologist's exploits. Let me start again with using the conventional radiography. Mr. Vice Chancellor, plain radiography remains the most widely available, affordable, and fundamental imaging modality in our environment. Despite its apparent simplicity, accurate interpretation requires a systematic step-by-step analysis of radiographed tissues using grayscale differentiation to distinguish normal from abnormal structures. This principle is well illustrated in a study titled Routine Chest Radiograph in Pre-Employment Medical Examinations for Health Workers, Time for Review of the Protocol, 2017. The study examined a long-standing practice of routinely requesting chest radiographs for prospective employees and students, largely due to concerns about infectious chest diseases in an endemic environment. While the intention was to safeguard workplace health, evidence from other settings had already begun to question the clinical value of this routine practice. Our study sought to determine whether this entrenched position was justified, particularly given that chest radiography involves exposure to ionizing radiation, the effects of which may manifest years later. We found that the majority of participants had normal chest findings as depicted in Fig 12, and while the most common abnormality identified, cardiomegaly, that is an enlarged heart, was not clinically significant enough to affect employability or job performances. Our conclusion was therefore very clear. Routine chest radiographs should not be indiscriminately requested for, but rather reserved for individuals with relevant symptoms and clinical indications. Figure 13 shows what we call an enlarged heart, and those are the things you have seen there. You can compare. This work underscores the central theme of my academic journey, that imaging, even in its most basic form, must be judiciously applied, carefully interpreted, and continuously re-evaluated in the light of evidence, patient safety, and available resources. Acquired immune deficiency syndrome (AIDS) remain a global pandemic, affecting an estimated 32.4 to 39.5 million people worldwide, with approximately 2 million deaths recorded annually from AIDS-related illnesses. Sub-Saharan Africa bears the greatest burden of the disease, and Nigeria continues to have the second largest population of people living with HIV and AIDS in the region, and the highest in West Africa. I hope our young people are listening. Of particular concern is HIV/TB co-infection, which significantly increases mobility and mortality and remains a major public health challenge. Radiological evaluation in HIV-infected patients is particularly challenging due to the considerable overlap in chest radiographic appearances of infectious and neoplastic conditions associated with immunosuppression. This variability often complicates interpretation and contributes to diagnostic uncertainty. It was against this background that our study study, chest radiographic patterns of patients with HIV/AIDS and tuberculosis co-infection was conducted. The study aimed to document chest radiographic patterns in HIV/TB co-infection and to examine their relationship with age, CD4 cell count, and established marker of immune status and HIV disease progression, with the ultimate goal of reducing diagnostic dilemmas and improving life expectancy. Figure 14 is an example of a typical TB patient chest radiograph in a non-HIV patient. The findings demonstrated that tuberculosis remained the most common opportunistic infection among HIV-positive individuals, reaffirming the continued relevance of chest radiography in the evaluation of patients in developing countries such as Nigeria. The predominance of female patients with a mean age of 35.09 years aligned with established epidemiological patterns of HIV/AIDS, reflecting increased biological vulnerability and sociocultural factors. Importantly, the study revealed that a normal chest radiograph does not exclude TB in HIV-infected patients. Profound immunosuppression may prevent the formation of granulomatous reactions, resulting in minimal or absent radiographic findings despite active disease. This observation places an added responsibility on clinicians to pursue further imaging, such as chest CT, where available, or complementary laboratory investigation. In contrast, normal chest radiographs are uncommon in TB patients without HIV infection. Table 1 is the data from that study dealing with the rates, the CD4 cell count, lymphocyte count, and chest findings in HIV/AIDS patients. While Table 2 is also from that same study, showing the effect of radiologic lung findings on CD4 cell count. Additional conclusions from this study highlighted that HIV predominantly affects young, economically productive individuals. TB co-infection was more frequent in male patients, and cavity lesions tended to occur unilaterally in the mid and lower brain zones. Weight loss correlated with declining immune status, while the blood CD4 and lymphocyte counts were observed in patients with cavity TB. Conversely, higher counts were associated with pneumonic patterns. Overall, the study reaffirmed that chest radiography remains a valuable tool for diagnosis, monitoring, and follow-up in HIV patients, both before and after treatment, even if settings where advanced imaging modalities are available. Olatunji Salako, 2016. Although the use of ionizing radiation in children, particularly neonates and infants, should be minimized due to heightened cellular sensitivity and the potential long-term risk of malignancy, economic constraints and the limited availability of alternatives, such as MRI, often making radiographic investigation of choice by adhering strictly to the ALARA principle and the image gently guidelines. Radiographic evaluation remains indispensable in neonatal care, especially in cases of respiratory distress at birth. One such example from our department involved a sound male neonate weighing 3.2 kilograms, delivered at 38 weeks gestation, who developed acute respiratory distress shortly after birth and was diagnosed with primary spontaneous pneumothorax using radiography. That is depicted in the next image. There you see the right pneumothorax, that is excess air in the right lung, and then there's the lung collapse on that same side. Routine clinical practice at Olabisi Onabanjo University Teaching Hospital revealed frequent radiographic evaluation of children presenting with exoskeletal pain, prompting a retrospective study titled Radiographic Pattern of Skeletal Trauma in Children, Olatunji 2013. This study showed a higher incidence of fractures in male children, likely resulting from road traffic injuries and falls. Upper limb fractures, particularly of the humerus, were most common, reflecting falls on outstretched hands. I'm sure those of us who are parents of young children will identify with this. While skull fractures predominantly resolved with the rectal bone, notably 7.5% of fractures were attributable to back trauma, highlighting the need for skilled personnel during delivery. Figure 43 shows an example of a supracondylar fracture in a child. As Nigeria's population continues to age, similar patterns of trauma were observed in the elderly. A study conducted in 2019, Olatunde Onabanjo, revealed that fractures were more common in women aged 60 to 70 years, while men were frequently involved in a road traffic accident. Falls emerged as a major contributor to mobility and mortality, with the femur bone being the most commonly fractured bone, followed by tibia and fibula, that is, the thigh bone followed by the leg bones. These findings underscore the vulnerability of the elderly and point to the urgent need for government policies that will provide social protection and injury prevention strategies to reduce available mobility and mortality. Figure 18 shows the fracture of the left femoral neck in an elderly patient. We have fluoroscopic imaging with the use of contrast media. The clinical relevance of contrast-enhanced fluoroscopic examination is well illustrated in several cases from our practice. The diagnosis of light found in an 18-month-old child, Olatunde 2000, and seen on Fig 19. While we have the plain radiograph of the abdomen of that child on your left, we also have that of the contrast showing the double appearance on the contrast view. This will have likely been missed and the patient potentially mismanaged without fluoroscopic assistance. Similarly, the identification of a missed diaphragmatic hernia in a polytraumatized patient, Olatunde 2010, as depicted in Fig 20, shows barium in the stomach seen above the diaphragm. The first image there shows an absent air bubble under the left diaphragm, whereas when the contrast was given, we saw that the stomach was actually right in the left lung. As well as the diagnosis of adenocarcinoma of the splenic flexure, Olatunde 2010, as shown in Fig 21. Fig 21, the first image there shows the sonogram of the spleen, showing puckering areas, giving you an impression as if the spleen has abscess, whereas when you interrogate it by doing a barium enema on that patient, you will see that the lesion is actually in the splenic flexure of that patient. This understands the continuing relevance of these techniques in complex clinical settings. The value of intercavitary contrast media is perhaps most clearly demonstrated in the investigation of female infertility using hysterosalpingography. This procedure, which involves cervical cannulation and contrast installation, allows detailed evaluation of both normal and pathological anatomy of the female reproductive tract. In a study on hysterosalpingography findings among women with infertility in Ogun State, Nigeria, Olatunde 2017. Secondary infertility was the most common indication, with uterine fibroids, cervical fibrosis, and bilateral tuber occlusion emerging as the common findings. These observations highlighted the need for caution in the management of pelvic infection, inflammatory conditions, and post-abortal or post-surgical uterine procedures in order to reduce fibrosis and preserve fertility. Fig 22 is an example of what you call an HSG in a woman showing uterine cavity and the fallopian tubes. The identification of congenital anomalies such as Elin-Wunderlich syndrome further illustrated the diagnostic power of contrast-based imaging in infertility evaluation. Figure 23 shows an HSG in a woman that shows two endocervical canals, right, opening into two divergent hemiuteri and elongated cone-shaped blind ending hemivaginally. There's no way you will have known except we had done the contrast studies. Contrast-enhanced fluoroscopic techniques also remain indispensable in urological practice, particularly in the assessment of urethral structure disease. Retrograde and mutilated cystourethropy performed using our regulated contrast media under fluoroscopic guidance provide simple, affordable, and reproducible methods for evaluating the lower urinary tract. These techniques allow accurate determination of the number, length, and location of structures, information that is critical for treatment planning and prognostication, thereby reaffirming their continued relevance despite the availability of more sophisticated but less accessible imaging technologies. This was clearly depicted in our study titled Patterns of Radiographic Findings in Vitreous Unisrography in Shagamu, Olatunji Ileku, and illustrated by Fig 24. If you look at Fig 24, there is a tight structure and the background region. Computerized tomographic studies. One of the most critical clinical applications of CT is the evaluation of acute stroke. In a study on stroke imaging, Olatunji in 2016, hypertension emerged as the most frequent underlying cause, with the frontal lobe being most commonly affected, the affected region. These findings reinforce the necessity of prompt brain CT imaging in all patients presenting with stroke or stroke-like symptoms, as early diagnosis significantly reduces morbidity and mortality. Figure 5 is an axial CT of the brain showing acute hemorrhage. And then 26, an axial image of the brain showing intracerebellar bleed. Computer tomography is equally indispensable in the assessment of head injuries, particularly those resulting from road traffic accidents. Its use in this context is not a matter of convenience or sophistication, but a clinical necessity. CT enables accurate detection of skull fractures, especially the depressed ones, and intracranial injuries that may be missed from brain radiographs, thereby allowing appropriate triage for neurosurgical interventions. Actually, many skull fractures are missed on brain radiographs, almost 70 to 75%. All right? So this was clearly demonstrated in a study titled Pattern of CT Findings in Head Injuries, a self-ordained tertiary hospital experience. In this study, a male to female ratio of 4.2 to 1 was observed. Intracranial hemorrhage was the most common finding, occurring in 32.8% of cases, and comprising intracerebral, extradural, and subdural hematomas. Hemocephalus was identified in 3.7% of patients. Skull fractures were present in 53.4% of cases, with lunar fractures accounting for 20.7% and depressed fractures for 12.1%. The figure 27 shows the CT of the brain with an acute infarct situation. You can see the area of hyperdensity as against the area of I needed to talk to that. Over. Fig 28, CT shows CT with a depressed skull fracture, all right, and encephalocele at the temporoparietal region. In other words, there is air. Apart from the depression, there is air seen in the head of that patient. While figure 29 shows a depressed skull fracture at the right frontal bone, in running ahead of them. Magnetic resonance imaging studies. The inaugural lecturer first gained hands-on experience with MRI during her non-spiritual exposure in the United Kingdom. Although our teaching hospital has yet to acquire an MRI facility, I remained actively engaged in MRI research through collaborations with colleagues in Lagos State University Teaching Hospital and private imaging centers in Lagos. One of such collaborative efforts examined the evaluation of obstructive jaundice using magnetic resonance cholangiopancreatography, MRCP, in the results limited setting. MRCP is a non-invasive alternative to endoscopic retrograde cholangiopancreatography and percutaneous transopathic cholangiopancreatography for the assessment of pancreaticobiliary disorders. Our study demonstrated that choledochondritis and cholelithiasis were more common in younger patients, aged 36 to 45 years, while carcinomas of the head of the pancreas predominated in older age groups, particularly between 56 and 75 years. The most frequent level of obstruction was the distal common bile duct with carcinoma of the pancreatic gland, emerging as the leading cause of obstructive jaundice, followed by periampullary tumors. This is shown in figure 31. These findings have provided an important foundation for more targeted surgical requirements and improved clinical decision-making in the management of pancreatic and biliary diseases within our sub-region. Ultrasonographic studies. Mr. Vice Chancellor, sir, I would like to state at this point that ultrasonography constitutes my principal areas of radiological research, and it is therefore fitting that I share some of my most significant academic and clinical experiences within the imaging modality. One of my earliest areas of ultrasonographic research focused on sickle cell disease, a highly prevalent genetic disorder among people of African descent. In a series of studies, Olatunji 2000, 2001, and 2003, ultrasonography was used to assess renal size and correlate findings with packed cell volume during both steady and crisis states. These studies demonstrated that renal size in sickle cell patients peaks relatively early, around the third decade of life, before declining, a finding likely related to chronic erythropoietic stress and progressive renal injury. Several ultrasonographic evaluation of the spleen challenge the long-held assumption of universal autosplenectomy in sickle cell disease patients. Our findings suggested that splenic atrophy may be more strongly influenced by endemic malaria, acting as a comorbid factor rather than sickle cell disease alone, especially in the context of improved supportive care. Another notable finding was the high prevalence of biliary sludge, a precursor to gallstone formation in sickle cell disease patients compared with age and sex matched controls. This observation underscored the need for regular surveillance to reduce morbidity associated with gallstone-related painful crises. Figure 32 is an ultrasonograph, okay, in a sickle cell disease patient showing gallbladder filled with sludge. Sludge is a precursor of gallstones. The usefulness of ultrasonography was further demonstrated in my work on pediatric ocular imaging. Fig 33 shows the ultrasonograph of the eye of a child. All right? At the time of our research, normative data for ocular dimensions in Nigerian children were lacking. In collaboration with a pediatric ophthalmologist, we conducted a study titled Effect of Age, Sex and Ocular Dimensions in Children in Southwest Nigeria. Olatunji. Using the beam mode ultrasonography, we measured axial ocular length, anterior chamber depth, lens thickness, and vitreous chamber depth in 468 children, aged 2 to 16. All ocular dimensions increased with age, and significant specs-related differences were noted, particularly in the left eye. These findings have important implications for refractive error correction, intraocular lens power calculation, and glaucoma risk assessment. Fortunately, we are in a week when the ophthalmologists are dealing with screening for glaucoma, the silent blinding disease, emphasizing that age and sex must be considered in pediatric ophthalmologic assessment. Table 3 is the table from that data on effect of height, weight, and BMI on axial length, while figure 34 shows the effect of age on axial length. Table 4 shows the table with the effect of age group on all the ocular dimensions that were measured. Ultrasonography also plays a critical role in the assessment of raised intracranial pressure, a potentially life-threatening condition arising from trauma, tumors, infections, hydrocephalus, or idiopathic intracranial hypertension. Although MRI is the preferred modality in emergency circumstances, finance and limited access to advanced imaging often necessitates alternative approaches. Measurement of optic nerve sheath diameter using ultrasound offers a rapid, non-invasive surrogate marker for raised intracranial pressure. Table 5 is the data from that study that shows us the measurement of optic nerve sheath diameter in comparing them in gender, age, height, weight, and BMI. In a cross-sectional observational study involving 468 children, Olatunji, we established a normative optic nerve sheath diameter values for our population. The optic nerve sheath diameter was found to increase with age, with values comparable to international data, despite differences in equipment and methodology. These findings confirmed that bedside ultrasonography can reliably aid rapid triage and management of pediatric neurological emergencies in resource-poor settings. Subsequent analysis demonstrated that optic nerve sheath diameter showed no significant correlation with height, weight, body mass index, or gender, further strengthening its clinical applicability. Figure 35 is the graph from that study, effect of age and optic nerve sheath diameter. Another important contribution involved sonographic evaluation of pediatric ocular trauma. In that study, Olatunji et al. Showed that ultrasound proved invaluable in diagnosing cataracts, vitreous hemorrhage, retinal detachment, choroidal detachment, and lens dislocation, particularly when ophthalmoscopic examination was limited by opaque media. The study also highlighted brain trauma in the most common cause of injury, raising an important public health concern regarding child discipline practices and unsafe play environment. Figure 36 to 38 shows the various ultrasonograph of vitreous hemorrhage, retinal detachment, and cataract in children. As my expertise expanded, I also pioneered the use of Doppler ultrasonography in our environment. At a time when both the technology and expertise were scarce, Doppler ultrasound expressed changes in sound frequency caused by moving blood flows to assess vascular flow. It has become indispensable in the diagnosis of deep vein thrombosis, peripheral arterial disease, aneurysms, and obstetrics and pediatric vascular assessment. Figure 39 aptly shows the image of an ultrasonograph showing plaque within a vessel. A retrospective pilot study, Olatunji Oduson, demonstrated the diagnostic effectiveness of Doppler ultrasound, particularly in confirming deep vein thrombosis, and laid the foundation for further vascular research. This culminated in a large study evaluating carotid Doppler parameters in patients with coexisting type 2 diabetes mellitus and hypertension. Adekoya Olatunji et al. Significant increases in carotid intima media thickness and altered flow velocities were observed, suggesting early subclinical arteriosclerosis. The study strongly advocated for routine carotid ultrasonography in a high-risk individual to enable early intervention and prevention of cardiovascular complications. In other words, it's not just your lipid profile, you also need to do a carotid ultrasonography. Ultrasonography has proven to be an extraordinarily versatile, safe and impactful imaging modality, one that allowed meaningful clinical research, improved patient care and diagnostic innovation, even with constrained environments. Conclusions, Mr. Vice Chancellor, sir. Medical imaging is a dynamic and at times deeply challenging field. From the serendipitous discovery of X-rays in 1895 to the current era of artificial intelligence-assisted image analysis, radiology has evolved as a remarkable place. As we stand at this point in history, it is evident that the specialty sits firmly at the heart of evidence-based medicine. Radiology today is in an unprecedented demand, not only in accurate diagnosis and appropriate treatment of known diseases, but also for the early detection and characterization of emerging treatment of known diseases, but also for the early detection of emerging conditions within our environment. Indeed, it now has therapeutic application in interventional radiology. This growing demand places a responsibility on us to strengthen the training of future doctors and radiologists alike. Despite advances in technology, conventional radiography will remain relevant and continue to dominate medical imaging practice, largely because it forms the foundation upon which diagnostic reasoning in medicine is built. However, it must be emphasized that no imaging modality can replace sound clinical judgment, adequate history taking, thorough physical examination, and a reasoned provisional diagnosis remained indispensable, both in formulating appropriate radiological requests and in interpreting imaging findings within the broader context of patient management. Like you had, we are doctors, so we need the history, we need the details. Demographic trends in Nigeria reveal a growing population at both extremes of age, children under 5 years and adults aged 60 years and above. These groups have unique and evolving healthcare needs that demand focused research and thoughtful imaging strategies. Much of my academic work has been rooted in ultrasonography, affirming its reliability and versatility in the evaluation of anatomical, physiological, and pathological conditions. Studies on ocular dimensions, lens thickness, and optic nerve sheath diameter in children have provided baseline data relevant not only to pediatric ophthalmology but also to adult practice, particularly in the assessment of glaucoma and raised intracranial pressure. While the accessibility and safety of ultrasonography make it an attractive investigative tool, it must be emphasized that its use, like all imaging, should be clinically justified, mindful of professional time and diagnostic purpose. Looking ahead, the role of the academic radiologist is set to expand beyond traditional teaching and diagnostic interpretation. The increasing scope of interventional radiology, including image-guided biopsies and minimal invasive therapies, will add significantly to existing workloads. This evolution will necessitate deliberate and structured training of both undergraduate and postgraduate medical doctors to ensure competence and sustainability. In the realm of research, the academic radiologist in Nigeria today balances heavy clinical responsibilities alongside teaching and scholarly pursuits. Collaborative research, now central to modern radiology, demands continuous learning, retraining, and engagement with evolving technologies. This in turn requires institutional support, professional commitment, and a collective shift away from individualistic perspectives towards shared academic advancement. Ultimately, the goal of radiological research is clear: to refine existing imaging techniques, develop new ones, and enhance diagnostic efficiency in ways that reduce treatment delays, improve outcomes, and serve humanity more effectively. As I conclude this 125th inaugural lecture, I reaffirm that radiology is far more than the interpretation of images, once dismissed as mere shadows. It is the exploitation of light beams and waves to eliminate disease, guide therapy, advance knowledge, and it stands as a critical pillar of modern medical practice. Recommendations. Mr. Vice Chancellor Star, in keeping with the tradition of inaugural lectures, I wish to offer a number of recommendations which I believe will be beneficial not only to our institution but also to healthcare delivery and medical education within our society. I appeal to my clinical colleagues who request radiological investigations to ensure that such requests are guided by adequate clinical evaluation and a reasoned provisional diagnosis. If it should not be considered insulting, let me add that request indicates age, sex, and full clinical details of the patient, which are vital information, facilitating accurate interpretation. Imaging should not be driven by the availability of fashionable modalities or perceived sophistication, nor by the cost of an investigation. Unnecessary or poorly indicated imaging not only burdens patients financially, but also may delay definitive diagnosis and treatment. In many instances, a carefully requested conventional radiogram or ultrasound examination is sufficient and often faster in resolving the clinical question. Second, the provision of adequate imaging equipment for both training and service delivery should no longer be a subject of debate, but a priority. For example, while the inaugural lecturer of today has acquired training in ultrasound-guided breast biopsy following mammographic evaluation, there is currently no functional mammography unit in our institution, despite the central role of mammography in breast cancer screening and diagnosis. This disconnect between training and infrastructure must be urgently addressed. Considering the length, rigor, and cost of training required to produce a radiologist and the central role of radiology and accreditation of medical schools by both the MDCN and NUC, it is concerning that essential imaging equipment remains unavailable or inadequately maintained. Where equipment does exist, prolonged downtime is common, often because equipment generally and high-end machines such as CT and MRI are acquired without a backup. The absence of these technologies contributes to medical tourism, delayed diagnosis, and increased mobility and mortality. I therefore recommend a collaborative partnership involving the Ogun State Ministries of Health and Education, the university, the teaching hospital, relevant professional bodies, public-spirited individuals, and corporate organizations to ensure sustainable procurement, maintenance, and utilization of imaging equipment in the state-only, publicly owned medical schools. In this regard, it is also important that equipment procurement should not occur through unilateral executive decisions without the input of end users. Adequate training of personnel prior to deployment, strict adherence to installation specifications, and enforceable maintenance agreements must form integral components of any acquisition process. Furthermore, there is an urgent need for the employment of additional academic radiologists. The current staffing level places an excessive burden on existing faculty who are required to teach, demonstrate procedures, provide clinical services, and conduct research, often simultaneously simultaneously and at short notice. Expanding the academic workforce will enhance teaching quality, promote locally relevant research, reduce burnout, and strengthen the global visibility of our institution. While commending the Vice Chancellor for the current promotion processes and improved appraisal timelines within the university, I wish to draw attention to the importance of case reports in radiology. Case reports play a vital role in clinical communication, innovation, and global knowledge exchange, reinforcing the principle that there is no never in medicine. However, their relative low weighting in promotion criteria may inadvertently discourage scholarly reporting of novel findings and procedures, despite their high acceptance in reputable international journals. I respectfully recommend a re-evaluation of their academic value within appraisal frameworks. Furthermore, the university should devise means by which research contributions from academic institutions can be communicated to government for proper implementation, either as policy or developed for use by the government, society, and individuals. Finally, the development of the Department of Radiology to include structured training programs for radiographers and specialist radiology nurses can no longer be deferred. When adequately equipped and staffed, the department is well positioned to contribute significantly to the training and retraining of these professionals who are indispensable to modern radiological practice. Together, radiologists, radiographers, radiology nurses form a cohesive and formidable team capable of improving diagnostic accuracy, procedural outcomes, and patient care. Acknowledgements. Mr. Vice Chancellor, sir, I begin this acknowledgement by giving all glory and honor to God Almighty, the author and finisher of my faith, who makes all things beautiful in his time, never late, never early, has brought this day to pass. For his unfailing grace and faithfulness, I am eternally grateful. May his holy name be praised forever. Amen. I won't be most ungrateful if I fail to acknowledge the late Dean of Radiology in Nigeria, Professor S.B. Lagundoyi, fondly called Papa Lad by his residents. In 1989, he admitted me into the residency program at the UCH Ibadan, thus determining the trajectory of my professional life. I remain deeply indebted to him. I owe profound gratitude to Professors Radio Goshende and Isaac Fatukasi, my first teachers in radiology, mentors, and now revered friends. I also acknowledge with deep affection Professor Millicent Obajimi, who I met as a senior registrar, but now has become a devoted teacher, mentor, family friend, and prayer partner. I sincerely appreciate Professor Adeyinka Abiodun, my senior colleague and friend, and my dependable authority in neuroradiology, and Professor Olufunso Komolafe, who graciously accommodated me in Ilorin when I had to transfer my work from research Ibadan to Ilorin to be with my family. I am deeply grateful to Professor Donald Amazikinze, my boss, my teacher, my senior colleague, my friend, and an erudite scholar, a true disciplinarian. He invited me to the National Postgraduate Medical College examinations, first as an observer and subsequently as an examiner. Sir, I am truly grateful. May heaven continue to smile on you and all us. I am thankful to all my colleagues during training in Ibadan. The list is a bit long. All right? I thank you for the privilege of shared paths. To my colleagues in Ilorin, Professor Wale Ogutoyinbo, Dr. Banke Ahovi, Professor Casey Bryan, and John Muhammadi, I remain grateful for the enduring radiology family bond we built together. I also acknowledge my junior colleagues and friends, Professor Shola Adesinu, Tope Bolu and Lekun Iboye, and the others. Thank you for making radiology a home where we could all thrive. I acknowledge with deep gratitude the entire management of Olabisi Onabanjo University Children's Hospital, ably headed by Dr. Mrs. Olubunmi Fatukasi, my sister, friend, and prayer partner, for giving me the privilege of access to patients and facilities for my research. My appreciation extends to my co-authors and collaborators, Dr. Adeoko, Dr. Ariba, Ashaoli, Adekoya, who is my current head of department, Dr. Nwokoro, Oyelekon, James Torobo, Soji Jagun, Mojisaba Olushola Bello, Bodunde, Professor Steru Ayoade, Professor Ayode Jiagbola, my VC, Shade Adekombi, Professor Bola Fetuga, and my provost and friend, Professor Tino Ogunlesi, my reviewer and dean, and OB of Ogunforona. I salute your dedication and value your companionship on this journey. I also thank Professor Subu, Sani, and Adiloro for their encouragement in co-authorship and insightful reviews. To my residents, Dr. Adeduyomi, Ashaolubukola, Adekoya Omobonike, Isnada Jibike, and Ifowoshishu, who are now consultants in their own rights. And those still in training, Tosin, Lara, Esther, Dami, Austin, who are senior registrars currently, and the registrars, I thank you for being part of this story. I acknowledge all members of the Department of Radiology of the University of the Olabisi Onabanjo University Teaching Hospital, past and present. I also recognize the FMC Abeokuta Radiology family. Thank you for hosting us when our facilities were down. My heartfelt appreciation goes to your grace, Bishop Olufina and Mama Tony Fakwe, the Archbishop of Lagos Ecclesiastical Province and Bishop of Rome Diocese, the priests and members of the Anglican Communion, and my retired Bishop, Bishop Oke, all the way from Egba. Thank you so much, sir. Your presence on Abeokuta, I cherish your fellowship of love. I also acknowledge my childhood friend and classmate from Form 1 in Ijero in 1968, Professor A.B.O. Omotosho and his wife. They must be somewhere online. I sincerely appreciate Papa Olusola Ajolori, Professor and Mrs. Banji Adeoye, my teachers in the pre-clinicals, Professor Venerable and Architect Ejunwu. They are not just my teachers, but my spiritual mentors and senior friends. I appreciate you both. My appreciation goes to the chaplaincy of the University of Ilorin Chapel of the Light, Professor and Professor Ademola Popola, the Ilorin 49 family. You are fantastic. Professor and Professor Mrs. Olon Tobarojo, the Adigoles, the Ola Oshebikons, Basam Akimboyo, Canon and Dr. Mrs. Aderigbe, Papa and Mama Osho, Professor and Mrs. Oyinka, my vicars, both past and present. Other important friends, too numerous to be mentioned individually, whether present physically or online. I appreciate you all. I lovingly appreciate my aunties, Mrs. Lara Oladumoye, Lola Falegon, Olori Bose Adeniyi, and uncles Israel Daranola, Bisi Jojide, Prophet Dipo Bamidele, Sunday Anibaloye, and others. To my siblings, Jide Omolayo, Tony Babalola, Yemisi Akwanta, and Tokunbo Babalola, thank you for believing in me. Olumide Kiitan Babalola, Tomisi Sheyi, and sweet mom Shadi, my sister and friend. I appreciate you deeply. I also acknowledge all my step brothers and sisters. I warmly appreciate the presence of my husband's family, Big Mom Ojerandi, Big Mom Igimbo, and Sini Mogaji, Sister Somi Fashikwe, and all their children. I also thank Papa and Mama Adeyemo of Ibadan, and Venerable Barrister Okbe and Professor Mrs. Folake Orede Ofogere, and their families for giving us their daughters and welcoming us into that family. Thank you. May God continue to honor you all, to our dear children. Jesus Tomisi and Omotola, Olorun Tobiloba and Igbagbosanmi and Oluwatoni. Thank you for your unwavering love, encouragement and sacrifices. Heaven will reward you. Your children shall rise to honor you. In Jesus' name. And to our precious grandchildren, Olaoluwa, Olamide, Emi Oluwa Darimi, you are treasures. Finally, there is one man in this place. He has a short stature, yet taller than all in this hall. Say Jesus Christ, my Lord and Savior, the man who took my hand from my father over 42 years ago and vowed before God and man to stand by me through thick and thin. Today, I rejoice that this honor did not come behind you. He has been my pillar, my reviewer, the reviewer of my manuscripts, late into the night, critiquing, analyzing data, drawing graphs, orienting images, quartering papers, teaching me the rudiments of academic writing, and investing sacrificially in my professional growth. Please join me in appreciating Professor Philip Olushola Olatunji, retired but not tired, my crown, my head, my joint here in the kingdom of God. Thank you. Mr. Vice Chancellor, sir, principal officers of the university, distinguished guests, gentlemen of the press and great earths, thank you for listening. I wish you all a safe journey back to your destination. Sorry I had to rush. I'm very sorry. Thank you.
Nothing less. Lead to my destiny. I will face to peace. I have vision. All of you, stand up, stand up, stand up.
Thank you. Let's have our seat. Distinguished Senate members, ladies and gentlemen, we are very glad that the inaugural lecturer has indeed acknowledged most of us here present today. But political demands that we must, in a special way, recognize some dignitaries in our midst today. And it is on this note that I want to, in the first instance, recognize Most Reverend Dr. Michael Olabisi Onabanjo, Bishop of the Diocese of Reno, Church of Nigeria. You are most welcome, sir. We are indeed honored for having us, having you in our midst today. On behalf of Senate, I appreciate you. Again, I want to recognize retired Reverend Samuel Olugari, retired Bishop Diocese of Ekiti West. We recognize you, sir. Thank you, and God bless you, sir. Let me also recognize Professor Danamat Lusowe Abiodun. We recognize you, ma, for having you in our midst. Thank you. I think I saw Dr. Odeonu. We are most recognized, sir. Thank you. God bless you, sir. And I also saw Professor Abasede while he was coming in. Thank you for honoring us with this, with your presence. I recognize everybody for coming. We cannot mention the name of everybody here. Thank you all for coming. God bless you. Very shortly, I will invite the Vice Chancellor to declare the ceremony closed. While the procession will go out in reverse order, we are all expected to stand up and remain standing. On this note, I humbly invite the Vice Chancellor to declare this the 125th Inaugural Lecture post. Vice Chancellor, sir.
It has been a very, very interesting topic. I continue to acknowledge the inaugural lecturers of today. Please round of applause again and again and again. As we say, I felt that always have students to do necessary before we register you. We go and check our own record as well. In fact, our own have been a very good research because we have built an average of 7,000 students per year in the last 5 years. So that's a very good number to actually conduct that research and see how many of them are actually having nothing in their chest. And so that we found that we don't really need to be asking them to do necessary when they are coming. Thank you for that advice. And that is very inspiring. I'm very sure that the inaugural lecture actually made it such a way that even the layman was able to understand, because that is one of the problems that we have in medical field, to pass across information that ordinary person on the field will understand what we have done over decades with the university. Ladies and gentlemen, on behalf of studies of this great university, I hereby declare the inaugural lecture of 125th closed.
Shall we rise as we have the academic procession in reverse order?
the spouse of the inaugural lecturer and their children should also join the procession immediately. Thank you very much. Professor Philip Olatunji and the children of the inaugural lecturer should immediately join the procession. Thank you very much. Thank you very much. We wish you